Hello, everyone. My name is Anne Marie White, and I am faculty at the University of Rochester and also Executive Director of the Children's Institute here in New York. And with colleagues Jill Kohlberg, Becky Nauman, and also Kristen Hassmiller-Litch of the University of North Carolina, Chapel Hill, we're pleased to present you our paper, Surfacing Systems Perspectives to Guide Action and Improve Collaboration in Comprehensive Community-Based Suicide Prevention. As we submitted this work as a work in progress, we're very pleased to be invited to present it now as a parallel session item. We'd also like to acknowledge the U.S. Centers for Disease Control and Prevention for their support of this work through the Injury Control Research Center for Suicide Prevention and its partnership in the Colorado National Collaborative, which includes partners from the Colorado Department of Public Health and Environment who also supported this work. I just like to take a moment to introduce the nature of the dynamic problem or focus on suicide, which is the 10th leading cause of death in the United States, and it accounts for about 1.5% of all deaths. We also know that that means about 50,000 people will die by suicide each year. And we also know that the risks differ by different age groups. For instance, among adolescents, it is the second leading cause of death, and it used to be the third leading cause of death. So now we know that across all ages and within specific age groups, we've seen increases in suicide in this millennium, despite increasing investments in both healthcare and public health approaches to reduce suicide. And this has occurred at the same time we've seen that it's been decreasing in other countries around the world. So we know that there's a structural cause of suicide that hasn't yet been addressed. And so we're asking, how can we reduce suicide by 20% in 5 years' time in U.S. counties where its growth is pronounced? And also asking this question is our partners, the Colorado National Collaborative, but we're going to be answering it now through the aid of System Dynamics. When we look at suicide, we want to understand that it's embedded in a broader network of types of violence and injury. Each of these forms of injury and violence shares similar risk and protective factors, such that one risk or protective factor can each lead to suicide as well as these other forms of violence and injury. And when we look at what some of these common risk and protective factors are, we do see from an ecological perspective that they're shared across different levels, at the community level, at the interpersonal level, at an individual level, and at society level. And when we look at these factors through this lens, we know we're dealing with hypercomplexity in terms of background causes. Our partners in the National Collaborative for Suicide Prevention want to take a broad view to address suicide both comprehensively and in a community-based way, in a manner that addresses these upstream risk and protective factors. That being the case, we propose that System Dynamics would be helpful to understand system-level change, as many different stakeholders are needed to come together to grow a collective capacity to reduce these injury burdens, and as we wanted to apply group model building methods in order to support the new collaborations that were being formed as part of the Colorado National Collaborative. As System Dynamics is an iterative process supported by other methods, we first wanted to empirically investigate whether and how completed suicides across counties in a state cluster in terms of suicide. We did use mortality data operationalized in two ways. One, in terms of counts, or total number of suicide deaths per year in a county, and the other was in terms of crude rate for the number of deaths per 100,000. The cluster analysis showed us that there were anywhere from 3 to 6 different patterns, and what we really see, what we present here is a 5-pattern solution. And what we see is that some counties indeed are experiencing exponential growth over time in Colorado. There's certainly some linear growth as well, and there are a host of counties that do have moderate changes, but maybe just a small linear increase as well. We also wanted to reference the literature to see what models had been done that we could be building from. So looking at prior work, we identified 3 papers. The first by Andrew Page et al., colleagues in Australia, and another one by Chung from 2015, and another one by Condarelli in 2016. And what we learned by examining each of these models is that they all have their own unique strengths, but none were well suited for this project's purpose, because our goal was to build a model that would work at a community or population level, again, at a county level geography. And we wanted to explore linkages with risk and protective factors pertaining to both violence and suicide, and have our work be grounded in stakeholder experiences, strengthened by existing theory, and working at the local levels. Our next phase of work was to engage in virtual group model building with a variety of stakeholders across many counties in Colorado that was involved with the Colorado National Collaborative. And we wanted them to reflect on their experiences and what they think is driving change or increase in suicide, both in their counties and also at state and national levels. And our specific objectives were to create a shared understanding amongst stakeholders about the interconnected risk and protective factors most impacting suicide and related injuries across Colorado's counties. And we wanted to reflect local and state community stakeholders' current system and approaches to suicide prevention, and also those that they were considering in terms of the collaborative approach for comprehensive suicide prevention across the state. We did a lot of this work towards the end of last summer and throughout the fall of 2019. And again, this was pre-COVID, but given the distances of people across the state that we wanted to engage, we increased feasibility by doing these sessions virtually through a Zoom meeting format. And we took the same model building scripts that are part of Scriptopedia and concatenated them in 4 90-minute virtual meetings spread over a few months. And we included some representatives in each meeting from the 3 counties and also at the state level. I wanted to show you a quick little picture of the Zoom, and you can see that we shared screens. We were all able to see one another's hand drawings via the screen as if we were in the room together. And we did a lot of the same things, such as naming variables that we thought would be linked to the patterns we hoped would be produced. And we did also perform evaluation, and we found that the participants were happy and content with doing this work in this modality. I wanted to quickly show you the full causal loop diagram that these sessions resulted in. And you can see that there are many areas of this model that involve the healthcare system, shaded here in gray, and also dynamic feedbacks that are more about community level features. And we see, for instance, that social connectedness as a community feature is interacting with healthcare systems features. We also see that there's capacity for suicide and internalized stress and stressful events, and one's coping all are highly interconnected and could be generating exponential growth that we are seeing. We drew several insights from this initial qualitative phase. First, stakeholders focused on suicide as a result of mounting problems and stress. Communities' responses to suicide were identified as being too brief due to stigma and a move-on culture. We also talked about the social contagion effect of suicide, and we identified an uptick in capacity for suicide due to the delayed impact of trauma, and also immediately. We did also discuss that guns and gun ownership was linked to suicide, both through violence and in terms of perceived community safety, then leading to people owning more guns. Stakeholders identified some key stocks that would link to suicide rates increasing. One was treatment capacity of the healthcare system. And they talked about that as that capacity became limited, it would result in reduced access to care, and that this ongoing distress and trauma would then linger and not get resolved through healthcare services, and would then also generate decrease to the utilization of the system because there's less trust in a system that hasn't been able to address people's needs in a timely way. Finally, we want to present what some key feedback structures are that we've identified from this work that we are now developing into stock and flow diagrams so we can move into the simulation phase. So we can see both the dynamic structure and the dynamic behavior and compare what this model produces as it relates to data from Colorado and potentially other sources as well. Our first ultra early simulation model focuses on reflecting those key accumulations described by participants, such as mounting problems, stress, and capacity for suicide. And our model focuses on this instead of processes that, let's say, move an individual from low risk to high risk of suicide, or sort of an aging chain model, which is what we saw, for instance, in the PAGE model. I want to quickly talk about 3 reinforcing loops, starting first with the occurrence of suicide. And as suicide goes up, the impact of suicide on the population goes up, which then leads to more people in the community being indicated for suicide or having acquired some risk. And as the risk goes up, suicides will go up. Also, building on the suicide occurrence, thinking, for instance, about the contagion effect or just increasing general awareness of methods for attempting and means for completing suicide. That as suicides go up, those capacities for suicide in the community can go up, which then would increase the probability of suicide and ultimately the occurrence of suicide. And finally, starting with this loop, as it relates to gun violence, we see that there's another kind of exposure that's occurring. And as people and communities experience gun violence, there's more people, again, being indicated because of there being an impact of the gun violence on the community. And we also see that in Colorado, there is a long culture of gun ownership in the state that's a norm in many areas. And we do see that the presence of guns can both increase the probability of suicide completions because it's a very lethal means or lethal approach when one attempts suicide as compared to using other approaches which have lower lethality rates. And we also see that having more guns in the community can lead, obviously, to more gun violence. So the structure of our simulation model, focusing on these key feedback loops, reflects the impacts of traumatic events, including suicide. It reflects increased capacity for suicide following a suicide in a community. And it also shows effects due to gun violence as another response to mounting stress or mounting problems when there isn't adequate strategies to mitigate those problems or prevent them in the community. Finally, we do have a working model now in Stella that can produce shapes that include some sorts of exponential growth, as we see here, and reflecting the patterns we did see in our cluster analysis. And we also see that there's a group of counties that perform, very steadily, maybe with a small linear increase, for instance, right here. And also we see that there are some counties that will have slightly increasing suicide burdens, which is over the year, but not to the same degree that's occurring in these other counties where there's clear period of exponential growth. And so we have a very good base now to work from moving ahead. And I look forward to taking some of your questions. Thank you.